Good afternoon and welcome to Pop Talk. I'm Hannah Patriot, Unitarian Universalist minister and proud board member of PopF, Pasadena's Organizing for Progress, leading Pasadena to become a model progressive city of the 21st century. And I'm joined by my co host, author, filmmaker, and Pasadena Weekly columnist, Ellen Snortland. Today on our show, we have a special Mother's Day conversation with a midwife, Dr. Mayri Leslie, who lives in the Washington, D.C. area. Welcome, Dr. Mayri.
Well, thank you. Thanks for having me.
Okay, let's just jump right in. I am so excited you're here with me. I think you're the longest standing friend I have from my college days. So I'm so proud you're with us. I have to ask you this because I don't think we've ever had a deep conversation about this. What made you shift into midwifery?
Well, this is not a typical story, but I had a baby. And after I had my first baby, I thought, and I had my first baby with a midwife, I thought maybe this is something I can do. And then I kind of went, nah, I can't do this. So I forgot about it until I had my second child. And when I had my second child, the desire to be a midwife wouldn't go away. It was like a calling. So I listened to it and I left the arts and went back to school and became a nurse and then became a midwife.
Oh, and I happened to be at your first birth, I'm proud to say, when Sean was born. So were you yourself born in a hospital? Do you know the history of your birth?
I don't know too much about it, but yes, I was born in a hospital.
Yeah, yeah, yeah. Me too. My mother, who was mostly really chill about everything, she still had bitterness toward the obstetrician who induced labor 2 weeks early so he could go on a golf vacation. So,
What?
it's like, yeah, yeah, that's the patriarchy.
Well,
Like,
yeah, I had a C-section at 10:30 at night because the doctor wanted to get a good night's sleep. So I guess not much has changed.
oh my God, oh my God. So, Mary, I've been dying to ask you this. Have you been watching Call the Midwife?
Yeah, I've been watching it since the beginning.
Yeah. Oh, tell
I
me how you feel about it.
it's very accurate. Like the birth scenes that they do on there and the medical conditions that they deal with and the sort of the culture they deal with. It's very accurate. I had the pleasure of hearing the woman who is the main consultant to the show. She's a midwife and she's the main consultant to the show, and she talked about what it was like doing filming them. And she said that whenever there was a live baby being used, in the shot, she would always be within a couple feet and be there to back them up and stuff. But no, I'm really happy it made it and it's so successful.
Yes. Successful across the pond. I mean, it's like one of these pleasures that when I mention it, at least one or two people in the gathering, whatever it is, go, yes, call the midwife. It just is so unlikely that that would be a hit in some ways, but it's so beautifully done. Of course,
Yeah,
it would be of course, it would be a hit.
Do you,
It's just
do
like,
you think that shows made more people want to have a midwife?
I think that's very possible. I mean,
Yeah.
there's a lot of things that can have somebody decide that they want a midwife, but I think the media is so powerful that I think that probably does contribute to it.
yeah, I was wondering if there'd been an uptick since it went on the air or not.
Yeah, I don't know if that's been tracked. Probably it has, but I don't know.
Yeah, I'm curious too. Do you take any kind of historical questions in a survey or a questionnaire when somebody signs up to be? Um, I don't even know the language to be midwifed. I don't know. How do you say that?
Well, we call them women.
Oh, yeah, that.
The term, the formal term is patient, but we try to stick to calling them women. But do you mean
Well,
if
well,
somebody's starting in my care, do I ask about their history?
yeah.
Oh yeah, absolutely.
But do you include in that how they decided to become? to have the services of a midwife. I don't know if there's a term for that. I knew you called them women. It wasn't that. It was like, what do they look up? What do they Google to find a local midwife? Just midwife local?
Yeah, and in the U.S., the primary type of midwife is called a nurse midwife.
Okay.
That's what I am. So I'm
Yeah.
both a nurse and a midwife.
Yeah.
That's not universal because in much of the world, there are two separate vocations. Midwife is separate from nurse, but so people decide to have a nurse midwife for the birth. I guess it's as simple as that.
Yeah. Yeah. I'm just curious how many of the people who decide to have a nurse midwife were born by a nurse midwife. Just curious if it goes into a family culture or not, or if you know about that.
I've had some clients who that was the case.
Uh-huh. Uh-huh.
And but given the age range that are having children now, it was during a period where hospital was definitely the dominant place. It's still the dominant place, but where midwives were, on the outside, and it's much less that way now.
Oh, well, that's great. So I'm curious, when I saw you last, you had talked about the increase in C-sections. Is that still going up or has it gone down?
It's kind of leveled off. So, and a lot of different professional organizations have gotten on board, and the professional organization for the obstetricians is the American College of Obstetricians and Gynecologists. And even they came on board several years ago with reducing unnecessary cesareans. And also, to your mom's point, reducing unnecessary inductions.
Yeah.
So things have improved in that way.
Oh, good. I'm just curious what impact that had on me as the newborn. I mean, it's like, wait, what? I wasn't ready to leave. It's like, maybe that's why I'm so pissed off all the time. I don't know.
You got evicted.
I know. And why I hate golf.
Well, I'm curious, when you do the intake and you get history from the moms, like, what are the most important aspects of that history?
I don't know that there's like one, certain aspects that are most important. We take a medical history, so we want to know about their health and any health issues they might have. If they've had a baby before, or if they've had a pregnancy before, we ask about that and how that went for them. And but we also ask questions like, tell me how you feel about this pregnancy. Because not everybody's thrilled to be pregnant.
Right.
And so sometimes they'll talk about the circumstances they're in, or relationship issues, or other things. And most of the time, it's people are really happy about it. But it's important to give them the space to be, kind of be where they are at that point in their pregnancy. And you have this intimate relationship with them for 7-8 months, where you're the person they see and can ask anything and talk about anything and talk about their feelings, and talk about being worried about being a parent, or worried about having 3 kids instead of 2, or things like that.
One of the things I love about Call the Midwife is in the move in the 60s to move the mothers to the hospital, and what a contrast that there would be a preference for hospital because it was modern, or and then seeing how progress for me is going back to the old way of giving birth. It's like, what this is all topsy-turvy.
Yeah, the move to the hospital was based on good PR and that it was somehow safer and like that. And we know now from studies that whether people have a birth in the hospital or they have it in a birth center or they have it at home, that the safety is about the same, that it's not much safer. And that's for somebody who's healthy. Somebody starts out the pregnancy and is healthy. If somebody has, a heart condition or something like that, the hospital is probably the best place for them. Not probably, it is. But I don't know how much you know about birth centers, but birth centers are just what they sound like. It's a center where you can go in and have your baby, but it's not in a hospital. It's a freestanding birth center. And that's a good model too. So midwives, however, most nurse midwives mostly work in the hospitals, interestingly enough.
One of my first jobs when I was soon out of college, I was an administrator at a birthing center and midwifery school. And there was one birth that I was downstairs in the office, and I felt it. Like I felt that door open. I could feel it. Like, oh, the baby was born. Like I just knew it.
Yeah.
It's that. I mean, that's got to be an incredible feeling when, like, it all comes out all right, and there's the baby. And I mean, talk about rewarding, right? Very rewarding experience.
Yeah. No, it's miraculous, and it's miraculous every time.
Yeah.
I used to say that when I stopped getting teary-eyed at births, I should stop being a midwife, because it's always moving, and women go through their own challenge in the labor, and some labors are really hard and some aren't, as hard. And when they have that baby, there's such a sense of triumph.
Yes.
And then and complete and total love for the baby, and the women for themselves too, I think. So it's pretty awesome.
Yeah. Oh my goodness. I've often fantasized about having kids in their tweens witness a live birth for the simple joy and majesty of it. And I have a feeling the impact would be more respect and less kind of nonchalance about getting into a sexual relationship, because
Right.
it's majestic. It's the perfect
Yeah.
model of macro and micro. Here it is, this baby, but it's also universal. It's baby, oh, I'm so honored.
I had a teenage niece come with me one day to work and asked to shadow me, and she got to see a birth. And
Wow.
At the time, she was really excited about it. And then later on, as she grew up, she talked about what a trauma it was for her.
It is traumatic. Births are traumatic. They're so dramatic.
Yeah, it is. I mean, I wouldn't say it's not automatically traumatic, but it's hard.
Yeah,
because
it's not an accident. Yeah, it's not an accident. They call it labor. They didn't call it vacation.
Right. We used to say they don't call it picnic.
Yeah.
Not a walk in the park.
Yeah. Oh my God.
When was the last birth you did?
Well, actually, it was 10 years ago, because I switched into academia and started teaching. And I remember it, like it was yesterday. I miss it, but I made a choice to go down a different path. And so now I make midwives. I generate new midwives. That's my way of contributing to the cause.
What do you see as a pattern with these students that you are teaching, as far as what their draw is to it?
It's pretty interesting because many of them have not had a baby, so it's not something that came out of their own personal experience. And these young, fiery women that just know they are meant to be a midwife, and um, and some of them know that, and they have a particular population that they want to work with, so they want to work on the Indian reservations, or they want to do overseas work, or they want to work with low-income families. But they're by and large just really young women who are really passionate. And then there are some that have had children, and their experiences doing that are part of what calls them to it.
Well, speaking of certain populations, I was curious what your take is on the really tragic instance of Black mothers dying in childbirth. There seems to be an issue that no one can really account for why so many Black mothers die in childbirth in this country. Do you have any take on that?
Well, I know that it's multifactorial, that some of it is systemic, and sometimes the way people are treated, but that doesn't explain it all.
No.
And that group of women also have more of other health problems. It's disproportionate. If you look into statistics about health, it's disproportionate for high blood pressure. It's disproportionate for diabetes, and so that's kind of the puzzle of it. Is that you can't zero in on one thing that is responsible for it, but this huge call of attention to the fact, I think, is making a difference, and having people really think a lot more about the care that people give.
I hope so. My biggest question I came up for you, Mary, is the new explosive data that we just learned from the census, that our birth rate has gone way down. Yeah. What did you think when you heard that?
I thought about last year and what a stressful year it was for everybody. And although the data is from
this is 10 years. Year.
Yeah, so it would be from that period before that, but it's been going down for several years. And I was kind of surprised by it too.
I mean, should we be worried about it?
No, I don't think so.
Is there enough of us already?
I think there's plenty of us to go around.
I think too that the cost of raising a child must factor into people's decisions.
Definitely.
It's like with student debt and all sorts of things that young people are having to deal with that I didn't have to deal with. I mean, I never had kids.
Well, one thing they don't tell you is that you have to pay for private school if you want daycare as soon as they're 6 months old. It is very expensive to pay for daycare. So right from the get-go, like, there's all these hidden costs that people don't think about. It's really kind of a crisis, the whole childcare situation. Like, no wonder people don't want to have kids. It's too stressful to even pay for childcare.
Yeah, and I think a lot of the people who are of childbearing choices right now saw what their parents went through, and it's like fewer people going, yeah, I want that. It's like,
well, in our culture, we're so spread out. We don't have our parents and aunts and uncles living nearby. I don't have any immediate family that lives near me, but really, to have kids these days, you kind of need that mother-in-law or that mom or dad around to help with childcare. Otherwise, it's very hard.
I agree.
Yeah. So, have you been writing a book? You know I would ask that, right?
Yeah, I was writing a book a while back, but I stopped doing that. What I've mostly been writing for years is articles for scientific journals and writing about research primarily, and a few editorials here and there.
Yeah, yeah. What kind of research?
I have a couple different areas that I work in, but the one that I'm most hot under the collar about, it has to do with the baby's umbilical cord. So when the baby's born, typical practice for many, many years has been to cut that cord as soon as the baby's born. You clamp it and cut it. And that's just been considered normal. And it turns out that when the baby's born, the placenta, which is up inside, is still pumping blood into the baby.
Right.
And that when you cut the cord early, you can leave behind in a full-term baby, you can leave behind as much as 30% of their blood supply. And in a preterm baby, it can be as much as 50% of their blood supply. So that has all sorts of implications, especially in the preterm baby, because they need that blood volume. And if they're challenged by being preterm, like they're sick or they're compromised in some way, that extra blood volume and those extra blood cells make a big difference and can even prevent a certain kind of hemorrhage, a brain hemorrhage that can cause death in a newborn. So what we now know is we shouldn't mess with that cord right away. You should just leave it and let it do its job. And
for how long? How long?
For how long? It depends on different factors, but generally 2 minutes is a minimum.
Wow.
And you can wait as much to 5 minutes, because the baby's got some room with that cord, so you can take the baby and put it into the mom's arms and still have that cord attached. But that's a big area that I'm working in, and they found some pretty remarkable things. See, I get going on this, but
oh, good.
Awesome.
They found some pretty remarkable things. Some colleagues of mine who are brilliant researchers did a follow-up with the babies. So ones that had their cord cut early and ones that had their cords cut late. And they found that the babies whose cord was cut later, in other words, they let it transfuse, had more myelination in their brain.
Wow.
And we know that in the first year of life, that if a baby's anemic, it can cause lifelong problems for that child, and it can cause developmental problems. And when you cut the cord early, you put them at risk of being anemic. But so we're just finding out all these little things. And it's one of these deals where if you just go back to what's sort of simple in nature, it was always to let that blood flow. And now we know it, so we're finding out all these miraculous things that it does. The baby gets more stem cells, it gets more red blood cells, more oxygen, etc. So anyway, that's a sort of an overview of it. So that's one of the things that I'm involved with.
Wow. And Mother Nature is no dummy. I mean, come on. She made the cord long enough for the mother to be able to hold it. I mean, come on. And then when the placenta comes out, or then the transfusion stops. Is that correct?
Yeah, it actually stops a little before that, while the placenta is still inside. Okay. And this might be too much, but if you look at the color of the cord at the time of the birth, the cord is kind of a vibrant blue because it's got blood pulsing through it. Wow. And what happens is, as we call it a transfusion, as the transfusion stops, the cord turns limp and white. Wow. So one of the things we try to teach providers is we call it wait for white.
Wow. Now this may be too much too, but what do you think about mothers eating their placenta?
Well, it goes back in history a long time. I've
But for
only
those
had,
who don't know, like why would a mom want to eat her placenta?
oh, because it's full of hormones. It's supposed to help with producing breast milk and helping her with like recovery and
Yeah, and postpartum depression,
yeah,
right?
yeah.
I
How
mean,
does how does one prepare it?
all right, I actually did this. I did it twice, but here's what you do. Like the first time I had a doula prepare it, like they dehydrate it and then you like put it in a coffee grinder and then you put it into capsules. And so you're just taking like 3 to 5 of these capsules, keep them in the fridge until they're gone. And what I found is it, like the first time I had a baby, I definitely had some postpartum depression. Second time, I didn't have any. And I think it's because I ate my placenta. Like it really, I mean, maybe it's a placebo effect, but I think it helped. It did help.
Well, most mammals do. That's one of the things to look at in terms of
Right.
nature.
Right. Yeah. It's not like you eat it with a knife and fork, like a steak or something.
No.
It's a little bit
I,
more
I,
involved.
had, I had a client. I had a client years ago, and what she did is she took it and chopped it into little tiny pieces that were, and then froze them,
Yeah.
and then she'd throw them in a milkshake.
Oh my God. I'd go for the capsule approach. Placenta milkshake. All right, you heard it here first, y'all.
Oh my God. Oh my God. It's like, yes, sauteed in butter with mushrooms, please. It's like,
Oh goodness. Hmm.
oh my God. The humor, placenta humor.
So another question we had is what was the most difficult birth that you attended?
That's easy to tell because I remember it, pretty clearly. But back, strangely enough, it involves an umbilical cord. But sometimes the baby, when they're inside and they're smaller, they kind of can swim around and get tangled in their cord.
Yep.
And so this baby had the cord around its neck 4 times.
Whoa.
And a lot of times those babies end up being a C-section because when the contraction, presses them down, it tightens the cord, and then their heart rate shows problems and stuff like that. But having the cord around the neck is not a big deal necessarily. Sometimes it is, but it isn't. But 4 times is pretty intense. And we kept thinking, okay, she's going to need a C-section. Okay, she's going to need a C-section. But we hung in there because in between the contractions, the baby's heart was fine. So, and when the baby comes out, you normally have enough room to clamp and cut the cord. But this was like trying to work with a basket weave. The way the cord was around the neck. Anyway, it was complicated, but the baby came out totally fine.
That's amazing. That my daughter had her cord around her neck a few times, and I had a C-section, but I'm glad I had a C-section because of that cord being around her neck, and who knows how that would have gone. So all's well that ends well.
So was that the doctor that also wanted to get a good night's sleep?
No, that was the first one. My second C-section was completely scheduled because we were trying to go to Canada and realized we have to get a passport for this child in time for this flight that we arranged. So yeah. But what's interesting, yeah, I came in that morning. She's like, "You actually started labor naturally. Do you want to just do that?" And I was like, "No, I'm good. Let's wheel me in, cut me out. Bing, bada boom." Yeah. And the cord was around her neck. So like, who knows? I don't know. I don't think I'm a little woman. It's hard for me to imagine being able to accomplish that. I think in 100 years ago, I might have died in childbirth. I would not be surprised. I think it's hard. It's so much harder for little women to have babies. So I'm very grateful for the C-section.
Yeah, it's a wonderful operation when you need it.
That's great. Well, go ahead.
Do you have the opportunity to have impact in the medical schools for obstetricians getting more on board with midwifery by any chance?
Yeah, well, before I went into teaching exclusively, I worked at universities. So I worked at University of California, San Diego. I worked at Georgetown. I worked at Yale. And big universities like that, they have, their resident program where the doctors come after they finish medical school. They come, and this is the 4 years they put in, to become doctors. And so they rotate through the different specialties. So there's a group of residents that's on labor and delivery all the time. And so we all work together. And you can even bring a resident in on a midwife birth and have them see what we do and what's different. Like you kind of go like, well, what's different? So one of the things is there's these hospital beds that are specially made for childbirth, and there's made so you can unhook the end of the bed and it turns into stirrups, etc. And that's primarily for the convenience of the provider, to make it easy for them to get in there and catch the baby and stuff. But you don't have to do that. And most women, that's not the most comfortable thing for them. So for instance, midwives, it's called breaking the bed. We don't break the bed. Now that's not always true. There's certain circumstances where we might, but so women with us can give birth laying on their side or on their hands and knees or sitting or laying down or whatever they want to do. So because there's this focus on autonomy, that the more autonomy you can leave intact for that mother, the more empowered she's going to be in meeting the challenges of her labor. So the residents learn by watching. We talk about different things. I've been places where the residents got a labor that's kind of stuck, and they'll go ask the midwife, what would you do in this situation? And I just had a woman who is a physician in LA. We reconnected because they'd asked me to come speak there. And she said, I was a resident with you and I learned so much from you. And to this day, she felt it was part of her education. So the answer is yes, there's opportunities like that.
That's great. That's great. Have you, how long have you been involved in midwifery from start to now?
In terms of when did I become a midwife?
When did you start studying to be a midwife?
Oh, pretty young. I have to go by my daughter's age because it was right after her birth. So I think she's 31, so about 30 years. Wow. And I used to, before I went to school to become midwife myself, I used to work with a home birth practice in Santa Barbara and go to attend home births and support women in labor. You mentioned a doula, and I was a doula for a long time. So that I was with a lot of women when they gave birth, but I didn't have any professional responsibility to, manage the birth or anything. But that was great.
I've been a little surprised with Call the Midwife that so many women were on their backs. For some reason, I thought more of them would be squatting or have a chair or historically, I don't know what the progression has been as far as position. They certainly put them on their sides and occasionally on their hands and knees. How do you discern which position is going to be best for the mother and for the baby?
I go by what does the mother want to do.
Uh-huh.
what are her instincts. And if it's like, if the labor's kind of going slow and she's doing a lot of pushing, let's say she's at the end, she's doing a lot of pushing and it's not going very fast, I might suggest different positions to try and because when you change position, it can slightly change the baby's position and maybe make it a little easier to come down. So I might suggest different positions, but it's really amazing. I mean, when you don't mess with the process and you just kind of let it go, she knows what to do.
Yeah. It would seem to be Mother Nature again, going,
Yeah.
tapping you on the shoulder, going, hey, try your hands and knees. And with the permission of a midwife, I mean, it seems to me that it would be easier to assert what you want with another woman. I don't know if that's true or not.
Yeah, I don't know either.
Yeah.
I think it depends on the relationship they've established with their provider. Now, not every, people see different providers throughout their pregnancy.
Uh-huh.
So the one that's with them when they deliver may or may not be somebody they're super familiar with.
Uh-huh.
A lot of practices are that way. The smaller practices, that's not necessarily true. You'll know the people you deliver with, but I just have seen a lot of births both in the hospital and out of the hospital, and just been really impressed with women's instincts.
Yeah, there's a book right there too.
Well, I remember at that birthing center I worked at, they had a hot tub. So you could do labor in the bath or even have the baby in the bath.
Mm-hmm.
Talk about that a little bit. Was that something that was kind of a trend for a while, and or is it still an option for a lot of birth centers?
It's still an option in a lot of places, and even people having home births will rent tubs to have at their home, for the labor and stuff. But it basically started out as a form of pain relief.
Mm-hmm.
When you're in the water, it helps reduce the amount of pain you're feeling. And people usually when they get in the water, they're very happy about it. And one of the places that this all got started in France, the doctor who was doing with the women, he said he never intended to do births in the tub, but he got to the point where women just wouldn't get out, that they were so comfortable in the water. So he said, what the heck, and started developing that. And what happens is the baby is already in a water environment inside because they're in the amniotic fluid inside. And so they're already, used to having fluids. So when they come out into the water, they don't try to take a breath, which would be the problem, if a baby aspirated the water. But they don't try to take a breath until their skin hits the air. And the impetus for them taking a breath is the air hitting their face. And again, that's a healthy baby, one that's not, compromised or something like that. So it's for healthy babies. But I've seen a lot of water births too, and they can be pretty great.
So
you're so clean afterwards.
Yes. So we're all actually somewhat of an amphibian.
Yeah, if you think about it.
Oh my goodness. So are there particular cultures that seem to be more inclined to go with a midwife? I mean, I don't know of any Norwegian Americans that have done that. But like French people or Native American people, or are there particular cultures where it seems closer to mom and grandmother and intergenerational?
Yeah, I mean, most of my experience has been with this Hispanic, with Latinas, and because I did a lot of my clinical work in California, and it's very accepted in that culture. But you have to get this perspective, excuse me, which is that in most of the world, the number one way people give birth is with a midwife.
Right.
The United States is flipped. We're backwards. So about 10% of the births in the United States are with midwives and about 90% with physicians. And in England, it's just reverse. It's about 90% midwives and about 10% physicians. And the physicians are the experts in abnormal or somebody who's sick or, twins, triplets, things like that. And they come in, they get involved in a labor a pregnancy or a labor because of complications, and that's their specialty. And the midwives, our specialty is low risk, healthy, births. And we have to, in our training, we have to know all the bad stuff too. We have to be able to recognize when something's not going right, or if there's a health concern. But in an ideal world, you have this team, and the team includes a midwife and includes a physician who's in the background if you need them for something. And that's the way it is in most of the world. So, and I don't know if you know about this, but the World Health Organization declared this year the year of the nurse and the midwife.
Really? No, I did not know that.
Yeah. And I just read a report, or I just read about a report that came out of WHO talking about the serious shortage of midwives in the world.
Interesting.
And how we still need more.
Well, I have a friend, her name's Jane Roberts, and she coordinated safe birth packets where they would include just very minimal kinds of equipment like sterilized scissors and
right.
a string, and that cost about $2 to put together just to disseminate throughout. I think she was working in sub-Saharan Africa the most, but geez, it just seems like it's such a good investment for everybody to have healthy children.
Yeah, I've done some work in Haiti, and in Haiti, they have most of their births are actually in the community at home, but it's not the same as kind of what I was talking about. It's because they can't afford to go to a doctor or to a birthing clinic or whatever. Right. So, and then they have the traditional, interestingly enough, both men and women, traditional men and women in the communities who help do the births. And the country took on, trying to make birth safer. And so they did those packets that you're talking about, which is like a clamp, a pair of scissors, some clean gauze, and one set of rubber gloves. And it's in a little Ziploc bag. Right. And they set up a program so that the people in the community that were working with the babies would have, the minimum desired.
I really want to hold a baby right now. My kids are big. I'm like, I haven't held a baby in so long. Oh.
I know what you mean. I saw a baby the other night in a restaurant, and this baby was probably 2 weeks old. And I just really wanted to go over and say, can I just for a couple minutes hold your baby? It's such a little guy.
I want to sniff babies. What's up with that? I also want to eat them. It's like I see pictures of darling little babies. I want to bite their cheeks. I want to bite them. I think that's weird, but there you go.
Well, sniffing makes sense because they smell wonderful.
They
do. Yeah.
Oh.
But I just want to bite those little cheeks. I just
Oh, that peach fuzz hair. Oh my god. Oh.
How old are your kids?
They are going on 10 and 12.
Oh boy.
Yeah, they're 9 and 11 now, but pretty soon I'll have 2 double digiters, Yeah.
Oh my god.
Well, so, happy Mother's Day. My goodness.
Yeah.
Yeah. Happy Mother's Day to everybody.
Yeah. So if you could make, let's put a magic wand in your hand, and if you could make anything happen in the midwifery field or in the culture at large, what would that blessing or poof, what would that shift be?
Well, it would have to be to more midwives. That would be what I would think. Because I think one of the reasons we have such high-tech births in this country, and we have, some of our problems with mortality, et cetera, is because we've got this system that's applying high-risk caregivers, people who are specialists at things, not being simple, and they're in charge of most of the births.
Wow.
And the truth is, birth itself is inherently safe, and about 90% of births don't need a lot of extra stuff. They don't need all the technology, et cetera. I mean, we have things in common. Like, we both need to listen to the baby's heart rate in labor, and we both need to kind of track how the labor's progressing, et cetera. But we've got high risk specialists taking care of most of the normal births in our country. And when you look at countries that have majority of midwives, their infant mortality rate and their maternal mortality rates are lower than ours.
Wow.
You'd think because we have all our resources and our technology that we would come out better than that, but we actually come out fairly low.
So you're basically saying less fuss, right? Keep it simple.
Well, it just seems to be a misapplication and misappropriation of resources.
Yeah.
I mean, really? It's like, oh my goodness, you know. Well, hopefully, Call the Midwife is going to provide some of that PR, because it's such a good show, and it makes it real for people. And I know that this is maybe a inappropriate analogy, but I know that after Animal Planet came out, a lot more kids wanted to be veterinarians. When they saw what veterinarians did, they're like, "Yeah, that's what I want." It's like, so hopefully, and that's happened with a lot of different TV programs. More kids wanting to become lawyers, or because if you can see it, you can be it. It's a very simple concept.
Yeah.
Yeah.
Well, I hope that's true. I hope there's more people but wanting to become midwives. But there in I work in a school, and we have a small midwifery program. But overall in the country, there's more people applying to midwifery schools than there are spaces in the midwifery schools.
Okay.
We actually need more midwifery schools.
Right. Yes.
Yeah.
Interesting. Well, this has been such a wonderful.
What?
What was that?
I said I might be a little prejudiced.
Yeah. Well,
me too, darn it.
Yeah, me too. Start more schools, more midwifery schools. Well, it's been such a pleasure hearing about what it's like to be a midwife. I certainly learned a few things. I didn't know that we could use more midwives, and all the stuff about the umbilical cord. I will not forget that. Well, keep up all your wonderful research. And did you have any final thoughts to share?
Oh gosh. Well, thank you first of all for having me and for, having this great conversation. I guess my, one of the core things that I believe that is probably worth sharing is that you can trust women. Women know themselves, they know their bodies. And if you had a care system that was centric on trusting women and empowering them and keeping their autonomy intact, you'd have a different healthcare system than we have currently.
I would just like to say how proud I am of you, Mary.
Yeah.
I'm just I'm just so proud of you, and I admire you and I respect you and I love you. Thank you so much for making a huge difference in so many people's lives and in the larger context too.
Thank you, Ellen.
Yeah.
That means a lot. And thank you for making a difference, just having the conversation so other people can hear it.
Yeah.
This was all Ellen's brilliant idea to interview a midwife before Mother's Day. So thank you, Ellen.
You're welcome.
Well, I guess we'll wrap up. And I'll just say that's all the time we have for Pop Talk. You can learn more about the good work of POP Pasadena's Organizing for Progress at poppasadena.com. You can find this episode posted on Radio Honolera's Facebook page. Please share widely. And it'll also be made available on POP's website. And we thank Radio Honolera for their tech support and making Pop Talk possible. Viewers and friends, thank you for listening. Good night and good luck.